Please start, sir.
All right. So a very good evening, everyone. So after having discussed about the cardiac emergencies in the last week, so now we will be discussing the endocrine emergencies. And what all will be the endocrine emergencies? The endocrine emergencies, they include the diabetic ketoacidosis, hyperosmolar non-ketotic coma, hypoglycemia, thyroid storm, Myxedema coma, Conn syndrome, adrenal crisis, Pheochromocytoma, Hypopituitarism, syndrome of inappropriate antidiuretic hormone. So these are the endocrine emergencies which we will be discussing. All right. So myself, Dr. Rajesh Gubba, I'm the general medicine educator. So you can follow me on my Instagram handle, that is Rajesh Gubba. So following my Instagram handle will be definitely useful for clearing your upcoming FMG exam and as well as the NEET PG exam as well, wherein I am posting every day some quick pointers, some clinical based questions, some image based questions on my Instagram handle, which will be definitely useful for your upcoming competitive exams. Having said this, let us start with the endocrine emergencies. And the first important endocrine emergency that I will be discussing is about the diabetic ketoacidosis. So I have already given you the list of the endocrine emergencies. Among that, the one which I will be discussing first will be diabetic ketoacidosis. Diabetic ketoacidosis, as you are very much aware of, it is more common in type 1 diabetic ketoacidosis. Sorry, it is more common in type 1 diabetes mellitus rather than type 2 diabetes mellitus. And it is one of the acute complications in type 1 diabetes mellitus. And what is the mechanism of emergency in case of diabetic ketoacidosis? The mechanism of emergency is the ketone bodies, they are positive. Okay. So it is the ketone bodies which are more acidic in nature. And it is the acidity which is being produced by the ketone bodies that will be responsible for emergency situation in case of diabetic ketoacidosis. And what are the ketone bodies? Acetone, acetoacetate, and beta hydroxybutyrate. And out of these three, the most acidic ketone body will be the beta hydroxybutyrate. So these ketone bodies, they give acidity. So the pH will be less than 7.36. Right, the pH will be less than 7.36. So the individual will develop acidity. And because of acidity, like what will be the clinical manifestation in these individuals? Because of decrease in the pH, the clinical features what they will have is dyspnea. Right, shortness of breath will be there. And other manifestations in these individuals will be profuse vomiting, and they will also have abdominal pain. And on examination, there is also abdominal tenderness. And there is a characteristic breathing pattern. It's a periodic breathing, and that is called as the Kussmaul's breathing. Okay, so that is what you will have in case of diabetic ketoacidosis. So please don't get confused with the Kussmaul's sign. Kussmaul's sign is different and Kussmaul's breathing is different. Kussmaul's sign, you will have that in case of restrictive cardiomyopathy, constrictive pericarditis, and in patients with right heart failure. So how will you investigate these patients with the diabetic ketoacidosis? Please remember, urine ketone bodies, it is not the investigation of choice. It is the plasma ketonemia, that or plasma ketone bodies, that will be the investigation of choice. Okay. Now the question is, why urine ketone bodies are not considered as the investigation of choice? We have one important ketone body, that is beta hydroxybutyrate. This beta hydroxybutyrate is the most acidic ketone body that does not appear in the urine. So that is the reason why we don't consider urine ketone bodies as the investigation of choice. It is the plasma ketonemia, which is the investigation of choice. And that is the reason why if you do ABG, you will have acidic pH. Now coming to the treatment in case of diabetic ketoacidosis. What will be the first line treatment? The first line treatment will be IV fluids. That is, you need to give normal saline. See, whenever you give normal saline, these patients, in what way this normal saline will be useful? They are very severely dehydrated because of profuse vomiting and all. They are very severely dehydrated. So whenever you give normal saline, it will resume the plasma volume and it increases the organ perfusion. And followed by that, we need to give insulin. And the type of insulin that we give is regular insulin. And the route of administration should be, the intravenous route of administration should be given. So initially, we give intravenous bolus of 10 units. Followed by that, we give an infusion at a rate of 0.1 unit per kg body weight per hour. That will be the infusion rate of the insulin. And whenever you are giving insulin infusion, you need to monitor the potassium levels, right? And if the potassium levels are reduced, you need to give IV KCl. And what is the indication of giving IV KCl? When the potassium levels are less than 5.1 milliequivalents per liter, then you need to give IV KCl. And these patients, they have acidosis. So that is the reason why you also need to give sodium bicarbonate. But when will you give sodium bicarbonate is when the pH is less than 7 or when the bicarbonate levels are less than 10 milliequivalents per liter, then you need to give IV sodium bicarbonate. And what is the most common precipitating factor for the development of diabetic ketoacidosis is infection. So you also need to treat the infection by giving the antibiotics. Okay, so that is about your diabetic ketoacidosis, which is one of the very important endocrine emergency commonly seen in type 1 diabetes mellitus. Coming to HONK, that is a hyperosmolar non-ketotic coma. Hyperosmolar non-ketotic coma, this is more common in type 2 rather than type 1 diabetes mellitus. Okay, and what is the mechanism for this complication is, in these patients, the ketone bodies will be absent, but there will be increased serum osmolarity, right? It is hyperosmolar, non-ketotic. The ketone bodies are absent. Non-ketotic coma, right? Hyperosmolar, non-ketotic coma. So the clinical features will be mainly the CNS manifestations will be there. And these CNS manifestations will be in the form of seizures, right? They are in the form of confusion, right? Or the individual will be in a state of altered sensorium. That will be the clinical features that you will have in patients with hyperosmolar non-ketotic coma. And how do you investigate these patients with HONK? Investigation is that there will be increased serum osmolarity, ketone bodies will be negative. And what will be the blood glucose levels? Blood glucose levels, they are in a range of 600 to 1200 milligrams per deciliter. That will be the levels of blood glucose in case of hyperosmolar non-ketotic coma. Whereas in diabetic ketoacidosis, the blood glucose levels will be more than 250 milligrams per deciliter. Whereas in HONK, they are in a range of 600 to 1200 milligrams per deciliter. Then how will you treat these patients? So investigations, increase in serum osmolarity, ketone body is negative, blood glucose levels are in a range of 600 to 1200 milligrams per deciliter. Then how do you treat is, even in case of HONK, the treatment is you need to give IV fluids. Okay, and the preferable IV fluid will be the half normal saline. Okay, half normal saline in the sense 0.45 normal saline, because it is hyperosmolarity. So that is the reason why the preferable IV fluid will be half normal saline, or even you can give even normal saline, but preferable will be the half normal saline. And followed by that, we give IV insulin. Okay, so this will be the treatment of HONK, hyperosmolar non-ketotic coma. And please remember, it is more common in type 2 diabetes mellitus rather than type 1 diabetes mellitus. Now, the next most important complication in diabetic patients is your hypoglycemia. Whenever the individual is on certain oral hypoglycemic agents like sulfonylureas, or when the patient is on insulin therapy, then there is high chance of development of the hypoglycemia. Now, in case of hypoglycemia, you need to remember one of the very, very important triad. And what will be that very important triad? That is Whipple's triad. This is a very important triad that you need to know. And what will be the features of the Whipple's triad? The individual will have the clinical features of hypoglycemia. And number two, whenever you estimate the blood glucose, there will be low plasma glucose concentration. And third important thing is, whenever you supplement the glucose, there will be relief of symptoms. Okay, there will be relief of symptoms on supplementing the glucose. This is what is your Whipple's triad, right? Symptoms consistent with hypoglycemia, low plasma glucose concentration, which is measured with a precise method. Third important is relief of symptoms after plasma glucose level is raised. This is what is your Whipple's triad. And in case of hypoglycemia, you need to know what are the compensatory mechanisms. Now, first and foremost, this is a multiple choice question. What is the first defense against hypoglycemia? The first defense against hypoglycemia will be decreased insulin concentration. And when will the insulin concentration reduce? When the blood glucose levels are around 80 milligrams per deciliter. That is the point when the insulin concentration or insulin level reduces. Followed by that, there will be increase in your counter-regulatory hormones. What are those? Glucagon, epinephrine, cortisol and growth hormone, and there will be decreased cognition as well. When will the glucagon level increase? And this is the first counter-regulatory hormone that will be elevated. So the glucagon increases when the blood glucose levels are at a range of 65 to 70 milligrams per deciliter. And when will the epinephrine increase? Same. When the blood glucose levels are in a range of 65 to 70, the epinephrine level increases. And similarly, even the cortisol also increases when the blood glucose concentration is around 65 to 70. But the first important counter-regulatory hormone that will get elevated is glucagon, followed by that epinephrine, followed by that cortisol, followed by that growth hormone. And when will there be decrease in the cognition? Cognition will reduce when the blood glucose levels are less than 50 milligrams per deciliter. That is the point when the cognition will be reduced. Okay. And what will be the clinical features? So mechanism is, you need to know the Whipple's triad, right? What will be the clinical features? You will have neuroglycopenic symptoms, right? Neuroglycopenic symptoms. And the individual will also have the clinical features due to increased sympathetic discharge. Okay, what are those neuroglycopenic symptoms? The neuroglycopenic manifestations include behavioral changes, confusion, fatigue. There can be seizures. There will be loss of consciousness. And if hypoglycemia is severe, there can be even death of the individual as well. So that will be neuroglycopenic manifestations. And what will be the clinical manifestations due to increased sympathetic discharge? Due to increased sympathetic discharge, the adrenergic symptoms will be there. Palpitations, tremors, anxiety, and even there will be profuse sweating, increased hunger. These are the adrenergic symptoms that you will have in patients with the hypoglycemia. And investigation is very simple, right? You need to do GRBS, random blood glucose should be done. And if the blood glucose levels are less than 70 milligrams per deciliter, then you need to give intravenous dextrose. Okay, so that is about your hypoglycemia, which is one of the very, very important endocrine emergency. If you don't treat, the individual may land up in death. Now, after having discussed about DKA, hyperosmolar non-ketotic coma and hypoglycemia, next you need to know thyroid emergencies, that is thyroid storm and Myxedema coma. Now, let me discuss about the thyroid storm. Thyroid storm, it is one of the rare manifestation, and it is a life-threatening exacerbation of hyperthyroidism, right? Life-threatening exacerbation of hyperthyroidism. Rizwan, neuroglycopenic means when the blood glucose levels or when the glucose levels within the neuronal cells reduces, the manifestations what you get is what is called as neuroglycopenic symptoms. Is that clear, Rizwan? Okay. Now coming to thyroid storm. Thyroid storm, it is abrupt increase in your T3 and as well as T4. That is what is your thyroid storm, which is also called thyrotoxic crisis. What is the problem in case of thyroid storm is the chance of mortality will be nearly around 30%. And what is the cause of mortality? Either because of cardiac failure or arrhythmia or hyperthermia. These three can constitute almost 30% causes for the mortality. Then in these individuals, you need to know what are the precipitating factors for the development of thyroid storm. The precipitating factors include acute illness. And what will be that acute illness? That acute illness that includes development of stroke, infection, trauma. These are the acute illnesses that can precipitate the thyroid storm, or even the surgery, right? Especially on thyroid surgery that can cause thyroid storm, okay? Or even the radioiodine treatment, even that can also cause the thyroid storm. And how will you investigate these ways? And what do you think will be the clinical manifestations? See, the clinical manifestations will be because of increase in thyroid hormone, the individual can have increase in the body temperature, fever because of increased metabolism. There can be delirium, seizures. That is another important clinical manifestation. The individual may also develop coma, vomiting, diarrhea. These are the manifestations: fever, delirium, seizures, coma, vomiting, and even diarrhea. Okay. Then how do you investigate? Definitely when you do a T3, T4 levels, T3, T4 levels are rapidly increased or abruptly increased. Then coming to the treatment in case of thyroid storm. So if you see the drug of choice will be nasogastric propyl thiouracil. And this propyl thiouracil, you have to give it in large doses, almost 500 to 1000 milligrams loading dose you have to give, followed by that 250 milligrams every 4 hours you have to give. That is by nasogastric tube. Or you can give even per rectum also. Even orally also can be given, but orally the individual might be in a state of delirium or seizures or in a stage of coma. So orally it is not preferable. Either by nasogastric tube or per rectum can be given. What it will do actually, propyl thiouracil, it will inhibit the peripheral conversion. T4 to T3 conversion can be inhibited by your propyl thiouracil. For suppose, if propyl thiouracil is not available, the other alternative drug is, we can give methimazole. Methimazole, it should be given at a dose of 20 milligrams every 6 hours. Okay. Now, after giving propyl thiouracil, after 1 hour, right? After 1 hour after giving propyl thiouracil, then you should give iodides. What are these iodides? That is your sodium iodide, potassium iodide, or Lugol's iodine can be given. What is the purpose of giving these iodides? These iodides, they block the thyroid hormone synthesis via Wolff-Chaikoff effect. And they prevent the release of thyroid hormone into the external circulation. So this will be the treatment. And apart from that, the beta blockers. And these beta blockers, which beta blockers we have to give in thyroid storm is propranolol. What is the purpose of giving propranolol? They will reduce tachycardia. That is the purpose of giving your propranolol. Or you can give short-acting beta blocker, esmolol can be given. That will prevent tachycardia and as well as arrhythmia. So that is about your thyroid storm. Okay. Next, coming to the myxedema coma. Myxedema coma, it is a form of a severe hypothyroidism, right? It is a form of severe hypothyroidism. So along with severe hypothyroidism, the hallmark feature is decreased level of consciousness. So the clinical feature will be decreased level of consciousness. That is the reason why it is called myxedema coma. And in which group of individuals you see this myxedema coma very commonly is in elderly individuals with history of long-standing untreated severe hypothyroidism, right? Long-standing untreated severe hypothyroidism. In those individuals, you see this myxedema coma. There will be reduced level of consciousness, and sometimes they may also develop even seizures. Along with that, there will be decrease in body temperature. There will be hypothermia. The body temperature can reach even 23 degrees centigrade as well. And there will be also hypoglycemia, decrease in glucose, hyponatremia, and there may also respiratory failure, hypoventilation leading to hypoxia and hypercapnia. These are the features of the myxedema coma. See, mortality in case of thyroid storm is around 30%, whereas mortality in case of myxedema coma is around 20 to 40%. Right? It is around 20 to 40% despite intensive treatment. Okay. Now, you should know the precipitating factors for myxedema coma. The precipitating factors will be mainly the sepsis that can precipitate the development of myxedema coma. And other precipitating factors are administration of drugs like hypnotics, narcotics, sedatives, antidepressants. They are also the precipitating factors for the development of myxedema coma. Exposure to cold is another important precipitating factors. And how will you investigate? Very simple. When you do T4 levels will be reduced and TSH levels will be increased. Okay, so that will be myxedema coma. Then coming to the treatment. Treatment is very, very important in case of myxedema coma. So if you see the treatment, you need to give intravenous formulation of thyroxine. Oral formulation does not work here. Okay, so you have to give intravenous formulation. And that too, intravenous T3 is more preferred than compared to that of intravenous T4. Why? Because in myxedema coma, conversion of T4 to T3 does not occur properly. It is impaired. That is the reason why intravenous levothyroxine, that is T3, is more preferred than compared to that of T4, which is levothyroxine. But only one important point you need to take care is whenever you are giving intravenous T3, it is more arrhythmogenic. It can provoke arrhythmias. So you need to monitor the development of arrhythmia, right? And apart from this intravenous T3 and as well as intravenous T4, there is hypoglycemia. So intravenous dextrose should be given. There is hyponatremia. So hypertonic saline should be given. And there is very severe hypothermia, right? There is very severe hypothermia. Temperature may go even up to 23 degrees centigrade. So whenever the temperature reduces less than 30 degrees, then you need to give external warming should be given, right? This is given when the body temperature is less than 30 degrees centigrade. Why? Because when body temperature reduces less than 30 degrees, it can result in cardiovascular collapse. So external warming definitely should be given. Along with that, in case of myxedema coma, you need to give intravenous hydrocortisone. What is the purpose of giving intravenous hydrocortisone? It should be administered because there is impaired adrenal reserve in case of myxedema coma. That is the reason why parenteral hydrocortisone should be given, and you need to treat any precipitating factor because sepsis is one of the very important precipitating factor. You need to give the broad spectrum antibiotics. So that is about your myxedema coma. Next, after having discussed about the endocrine emergencies like diabetic ketoacidosis, HONK, hyperosmolar non-ketotic coma, hypoglycemia, thyroid storm, and myxedema coma, let me discuss another important set of the endocrine emergencies, that is Conn syndrome. So Conn syndrome is what? It is hyperaldosteronism. As such, Conn syndrome, because of increase in aldosterone, it may not land up in emergency, but because of increase in aldosterone, that can cause decrease in potassium levels. Very severe hypokalemia can develop in case of Conn syndrome. Once there is development of severe hypokalemia, the individual will develop the ventricular arrhythmias. And this ventricular arrhythmias, because of hypokalemia, that can predispose the individual to an endocrine emergency. Okay. Now, in case of Conn syndrome, what do you think will be the first line investigation? The first line investigation will be aldosterone-renin ratio. Aldosterone-renin ratio will be elevated in case of the Conn syndrome. But what is the investigation of choice in case of Conn syndrome? Investigation of choice is oral salt solution test. And if the individual is unable to take the oral salt solution test, then you need to do IV saline suppression test. That will be the investigation of choice in case of the Conn syndrome. Then, how do you treat these patients with the Conn syndrome? See, what are we very much worried about? Ventricular arrhythmias. So you need to do ECG. If there is ventricular arrhythmias, you will have broad complex tachycardias. That is what the ECG show. If the patient with the Conn syndrome develops ventricular arrhythmia, secondary to hypokalemia. Now, how do you treat these patients? See, ventricular arrhythmias, if you want to treat, if the individual is hemodynamically unstable, then you need to give TC cardioversion of nearly around 200 to 360 joules you have to give. For suppose if the individual is hemodynamically stable, then you can give lignocaine, or the other alternative drug is the amiodarone can be given. Along with this, there is hypokalemia. You need to give intravenous potassium chloride. That is very, very important. Okay. And how do you treat Conn syndrome as such? So if you take Conn syndrome, it is hyperaldosteronism. So you need to give aldosterone antagonists. And what are those aldosterone antagonists? That will be spironolactone. But the problem with the spironolactone is it can cause tender gynecomastia. So the alternative to spironolactone is your eplerenone. That will be your treatment for Conn syndrome. But actually, what is the treatment of choice for Conn syndrome? The treatment of choice for Conn syndrome is surgical excision of the tumor. But when will you give aldosterone antagonist? When there is bilateral adrenal tumor causing hyperaldosteronism, then we give spironolactone or eplerenone should be given. If it is unilateral adrenal adenoma, then surgical treatment or surgical resection of the tumor will be the treatment of choice in case of Conn syndrome. Okay, so this is about Conn syndrome, which is one of the important endocrine emergency. Okay, and why Conn syndrome is endocrine emergency? Because of hypokalemia, the individual may develop ventricular arrhythmias, and that is making the Conn syndrome as one of the endocrine emergency. Okay, right. Coming to the adrenal crisis. So if you take adrenal crisis, it is abrupt decrease in all adrenal cortical hormones. That is decrease in corticosteroids, decrease in mineralocorticoids, and decrease in the weak sex hormones. Because of this, the individual may develop adrenal crisis. That it should be abrupt fall. But what would be the cause for the adrenal crisis? The mechanism is, or the etiology is, Waterhouse-Friderichsen syndrome, right? And this Waterhouse-Friderichsen syndrome is nothing but acute adrenocortical insufficiency. And this is very common in newborns, where there will be massive adrenal hemorrhage, right? Where there will be a massive adrenal hemorrhage. And what is the organism that can cause Waterhouse-Friderichsen syndrome? It is secondary to bacterial infections. And that bacterial infection, very common, is meningococcal infection, that is Neisseria meningitis, followed by that Pseudomonas. Okay, so that is another important organism which can cause the Waterhouse-Friderichsen syndrome. But what will be the clinical presentation in case of acute adrenal crisis? There will be very severe vomiting, and along with this, there will be severe abdominal pain because adrenal hemorrhage is there. And there is abrupt fall in your aldosterone and as well as corticosteroids. So there will be hypotension, because of which there can be decreased cerebral perfusion, where the individual may develop coma, vascular collapse, and finally death of the individual. These will be the features of your acute adrenal crisis. Then, how do you investigate this acute adrenal crisis? See, you need to do a co-syntopin test. Co-syntopin test is also one of the very important investigation in case of Addison's. So you can do a co-syntopin test, or you can check the steroid levels and as well as the aldosterone levels. Then coming to the treatment, what is the drug of choice for adrenal crisis? The drug of choice will be intravenous hydrocortisone. And why is that we are giving hydrocortisone? That is because this hydrocortisone, it has the dual activity. It has mineralocorticoid activity, that is aldosterone activity, and it is also having, or it also has the glucocorticoid activity. And that is the reason why we give intravenous hydrocortisone as the drug of choice. Okay, so this is about your adrenal crisis, which is one of the endocrine emergency, right? It is secondary to your Neisseria meningitis. So that is the reason why even antibiotic is also a mainstay of treatment in these individuals. Okay, right. Now, after having discussed about the adrenal crisis, the next important is the pheochromocytoma. Now, why the pheochromocytoma is an endocrine emergency? Why? Because pheochromocytoma, what is a mechanism where there is massive release of catecholamines, right? Massive release of catecholamines. And it is a tumor of your adrenal medulla. And basically, it's a tumor which is originating from neuroendocrine cells, which are nothing but chromaffin cells. And what is the hormone which is predominantly produced in pheochromocytoma? It is norepinephrine, which is predominantly produced, then compared to that of your epinephrine or dopamine. Now, why is that we need to consider pheochromocytoma as an endocrine emergency? Most of the patients with pheochromocytoma, they present with headache. That is because of hypertension. But in pheochromocytoma, because of massive release of catecholamines, by acting on the heart, the individual can develop the ventricular arrhythmias. So what are we very much worried about is your ventricular arrhythmias, ventricular tachycardia or ventricular fibrillation. And because of which the patient will present with palpitations. But otherwise, what is the most common symptom in these individuals? Most common symptom will be headache. And that headache will be occipital headache, and that is mainly because of your hypertension. Then, how do you investigate these patients with the pheochromocytoma? The first line investigation in case of pheochromocytoma is 24-hour urinary metabolites of catecholamines are increased, and particularly VMA, vanillyl mannalic acid levels are elevated. That will be the first line investigation. But what is the investigation of choice? That is plasma metanephrine levels or plasma catecholamine levels are elevated. And how many times it should be elevated? It should be elevated more than 4 times. Okay. And if it is elevated less than 4 times, it can occur even because of increased sympathetic discharge in anxiety and emotions as well. Then how will you differentiate if the levels are increased less than 4 times? Then we need to do clonidine suppression test. Then clonidine suppression test can suppress the catecholamines which are increased because of anxiety and emotions. But that clonidine suppression test cannot reduce the catecholamines which are increased because of the pheochromocytoma. And the clonidine, the dosage what we give is 0.3 milligrams of clonidine that we need to give. And in pheochromocytoma, what is the treatment of choice? The treatment of choice will be surgical resection of the tumor. But before doing surgical resection, you need to reduce the blood pressure to less than 160/90. So in order to reduce the blood pressure to less than 160/90, you need to give phenoxybenzamine, which is an alpha blocker. And another alternative antihypertensive that can be given is labetalol. But while doing surgical resection, if there is intraoperative hypertensive crisis, then we give phentolamine. So that will be the treatment for your pheochromocytoma. And if it is development of ventricular arrhythmias, just now we have discussed in Conn syndrome also. Like if the individual is hemodynamically unstable, DC cardioversion, 200 to 360 joules. And if the individual is hemodynamically stable, then lignocaine and followed by that amiodarone for maintenance can be given. So that is about your Pheochromocytoma, why is it considered as an endocrine emergency? Okay, next, followed by that, the hypopituitarism. Now, hypopituitarism is what? It is mainly reduction of the anterior pituitary hormones. Okay, mainly reduction of partial or complete loss of the anterior pituitary hormones. What are those? Growth hormone, ACTH, prolactin, luteinizing hormone, follicle stimulating hormone, and thyroid stimulating hormone. But the question is, what is the most common cause of panhypopituitarism? The most common cause of panhypopituitarism will be pituitary adenomas. Pituitary adenomas, that will be the most common cause of panhypopituitarism. Actually, we have many other causes like hypothalamic tumors, cysts, craniopharyngiomas, meningiomas, gliomas, and we have a condition called pituitary apoplexy, where there is acute hemorrhagic infarction of pre-existing pituitary adenoma. Even that can also cause the hypopituitarism. And some inflammatory diseases, like granulomatous diseases like sarcoidosis and tuberculosis, eosinophilic granuloma, and autoimmune lymphocytic hypophysitis. Even trauma, radiation, surgery, all these can cause hypopituitarism. And postpartum, if there is hypopituitarism, we need to consider Sheehan syndrome, which is nothing but due to postpartum hemorrhage. Okay. And in the clinical features, if you observe, the first hormone that will be reduced is growth hormone, followed by that, your your LH and FSH will be reduced. And the clinical features, what we consider to be more serious, is mainly because of decrease in the steroids. That is very much worrisome. And that is because of decrease in your ACTH levels. And how will you investigate this? The first hormone which is being reduced is growth hormone. So what you need to do is, the most reliable stimulus for growth hormone secretion is insulin-induced hypoglycemia. Okay, the investigation is insulin-induced hypoglycemia. Normally, whenever you give insulin, what will happen? The blood glucose level reduces. When blood glucose level reduces, growth hormone should increase. But in spite of hypoglycemia, growth hormone will not increase. That tells that the individual is having hypopituitarism. Okay, so it is a provocative test. It is a provocative test. Random growth hormone or IGF levels, they are not sensitive. Why? Because there will be pulsatile release of growth hormone and IGF. So that is the reason why random growth hormone and IGF, they are not sensitive. Right? Then coming to the treatment, what is the drug of choice? Drug of choice will be steroids. The first important drug that need to be given is steroids. That is because of decrease in ACTH, there will be decrease in steroids, where the individual will have very severe hypotension. That is the reason why you should give steroids as the first line drug. Subsequently, you can give growth hormone and other drugs. Okay, so that is about your hypopituitarism, which is one of the endocrine emergency. Coming to SIADH, syndrome of inappropriate antidiuretic hormone. What is the mechanism of SIADH considering as endocrine emergency? In SIADH, there will be development of hyponatremia. Why is that? Because in SIADH, there will be inhibition of your renin-angiotensin-aldosterone system, and there will be excessive release of atrial natriuretic peptide. These two can predispose to the development of hyponatremia. And because of hyponatremia, the individual will be in a state of altered sensorium. The individual can have loss of consciousness, projectile vomiting, seizures, severe headache. At one point of time, the individual may land up in coma and death. These are all the features of your hyponatremia. And how do you investigate these patients with SIADH? If you take the investigations in patients with SIADH, the urine osmolality will be elevated. Urine sodium will also be elevated. Serum osmolality will be reduced. Serum sodium will be reduced. And the investigation of choice is water loading test. Okay, that will be the investigation of choice in case of SIADH. Then how do you treat these patients with SIADH? The treatment of SIADH, drug of choice will be Vaptans. That is vasopressin receptor antagonist. That is, we have tolvaptan and as well as conivaptan. Tolvaptan we give oral formulation, conivaptan intravenous formulation. And hyponatremia, how will you do? You need to give hypertonic saline, that is 3% sodium chloride should be given. And you should also restrict the water intake. So that is about your SIADH. So what is the mechanism of SIADH causing endocrine emergency? That is because of hyponatremia, right? So after having discussed this set of endocrine emergencies, we have two more endocrine emergencies, that is hypoparathyroidism and as well as hyperparathyroidism. Now you take hypoparathyroidism, there will be hypocalcemia. See, because of hypocalcemia, you will have tetany, you will have perioral paresthesias, periungual paresthesias. These are not emergencies. Whenever there is hypocalcemia, there will be prolonged QT interval. And this prolonged QT interval, this can predispose an individual to develop polymorphic ventricular tachycardia. And this polymorphic ventricular tachycardia, which will develop because of hypocalcemia, that makes hypoparathyroidism as an endocrine emergency. These patients with polymorphic ventricular tachycardia, if you don't treat, what you will see is the death of the patient. So how will you investigate that? Calcium levels will be reduced. And when you do an ECG, ECG will show you a long QT interval. Okay, where the QT interval will be more than 460 milliseconds. And how do you treat these patients with polymorphic ventricular tachycardia? Basically, it is nothing but Torsades D pointes. So drug of choice for Torsades D pointes will be magnesium sulfate. Okay, and apart from that, you need to give calcium gluconate. Because the Torsades D pointes, whichever is developing, is because of your hypocalcemia. That is the reason why you need to give calcium gluconate. Okay, so hypoparathyroidism, how is it responsible for endocrine emergency? That is by hypocalcemia causing long QT interval, causing polymorphic ventricular tachycardia. And what is the cause of death in case of hypocalcemia? The cause of death in case of hypocalcemia will be laryngospasm. Okay, now hyperparathyroidism, that is also one of the endocrine emergency. Why? I'll tell you. There will be increasing calcium levels. Normal calcium levels are 9 to 11 milligrams per deciliter. And see, because of hypercalcemia, you have manifestations like renal calculi, pseudohypertension, calcinosis cutis, secondary Parkinsonism. These are all not endocrine emergencies of hyperparathyroidism. But when the calcium levels are increased to 13 to 14 milligrams percentage, the individual can have a systolic arrest and death of the individual. So how is your hyperparathyroidism responsible for endocrine emergency? That is because of severe hypercalcemia causing systolic arrest. And how do you investigate this? There will be increase in your parathormone levels. There will be increase in your calcium levels as well. But most common cause of hyperparathyroidism is parathyroid adenoma. And for localizing parathyroid adenoma, we do technetium 99M sesame B scan. That is for localizing that parathyroid adenoma. Most common cause is solitary parathyroid adenoma. Then we have many other causes like parathyroid hyperplasia, parathyroid carcinoma, and we have secondary hyperparathyroidism secondary to chronic renal failure, vitamin D deficiency, malabsorption syndrome, medullary carcinoma of thyroid. So these are all other causes. But primary hyperparathyroidism causing hypercalcemia at a range of 13 to 14 milligrams percentage causing systolic arrest, that will be responsible for an endocrine emergency secondary to hyperparathyroidism. And how do you treat these patients? Okay, so for treating hypercalcemia, the first line treatment you need to give is normal saline. that will cause the dilution effect of the hypercalcemia. And the drug of choice will be bisphosphonate. You can give ibandronate. Okay, what this ibandronate will do? That will reduce the calcium absorption from the bone, which is secondary to hyperparathyroidism. Okay, so this is about your endocrine emergencies. If you have any doubts, you can just ask me. Definitely, I'll answer your questions. Any doubts up until here? Right. So if you have any doubts, you can text me on my Instagram handle, that is Rajesh Gubba. So you can follow me on my Instagram handle, which will be definitely useful for you for your upcoming competitive exams like NEET PG and as well as FMG, wherein daily I'll be posting some quick pointers related to general medicine, image-based questions, clinical-based questions, the previous NEET PG questions, FMG questions, all that I'm posting on my Instagram handle, which will be definitely useful for you, right? So thank you very much. See you the next session. I will be discussing emergencies related to neurology. And any doubts, you can text me on my Instagram handle. Thank you very much. See you in the next session.